We send kids to school to learn, like, geometry and history.
Right, the basics.
Yeah, exactly. But right now, beneath the surface, schools are quietly being forced to operate as these frontline triage centers for some of the most lethal psychiatric conditions in the country.
Oh,
I
absolutely.
mean, the locker rooms, the hallways, the cafeteria, they are no longer just spaces for socializing. They are the primary observation wards for a really escalating health crisis.
It is a profound shift in the architectural purpose of the school building, really.
Yeah.
Because, we have historically separated education from clinical health care. We just assumed a student's medical needs would be handled by some pediatrician off campus.
Right. Like, that's a home problem, not a school problem.
Exactly. But the reality of modern public health is basically crashing through the school doors.
Hmm.
It's forcing educators to become first responders to complex psychological emergencies, whether they are trained for it or not.
Which brings us directly to our mission for you today. We are breaking down a highly revealing operational model. It's called the MentalSpace School Guide to Adolescent Eating Disorders.
Yeah, this guide is really eye-opening.
It really is. Our goal is to dissect exactly how schools, specifically looking at the state of Georgia right now, are confronting this high mortality epidemic using a radically different same-day teletherapy structure.
Right.
So, okay, let's unpack this, because we aren't talking about generalized teenage angst here. We are talking about critical, life-threatening conditions landing squarely on the desks of high school math teachers and school nurses.
Well, what's fascinating here is that when you analyze the mechanics of this mental space model, it immediately stops being just a medical or administrative document.
Oh, totally. It's so much more than that.
Right. It functions as a comprehensive blueprint for systemic survival.
Yeah.
I mean, it identifies a terrifying, dangerous gap between daily educational life and urgent psychiatric care.
Yeah, and it proposes a very specific structural fix to bridge that gap before more students just fall through it.
Exactly. But to really understand the mechanics of that structural fix, we have to look at how we define the problem itself.
Which, for most of us, means completely tearing down our outdated, culturally ingrained assumptions.
Oh, 100%.
If you ask the average person to picture a teenager with an eating disorder, they're going to picture a very specific demographic, almost universally, like a wealthy, thin, white teenage girl.
Right. But the data coming out of Georgia paints a completely different reality.
It really does. The demographic truth is just so much wider and honestly much more alarming.
Yeah, adolescent eating disorders are rising across the board. And they are striking teens of every race, every body size, every gender, and every income level.
Wow.
We are talking about a spectrum of severe conditions. So there's anorexia nervosa, which is characterized by severe restriction. There's bulimia nervosa, involving cycles of binging and compensatory behaviors.
Right.
And then there is ARFID, avoidant restrictive food intake disorder.
Okay, let's pause and actually look at ARFID for a second, because I think a lot of people listening might not recognize that acronym.
Oh, sure.
It presents very differently from anorexia, doesn't it?
Radically different. I mean, anorexia is typically driven by a distorted body image and an intense fear of weight gain.
Right, that's what we usually see in the media.
Exactly.
Yeah.
But ARFD, on the other hand, is often completely disconnected from body image. It is driven by extreme sensory aversions to the taste, texture, or smell of food,
Oh, wow.
or even a paralyzing fear of adverse consequences, like choking or vomiting. So a student with ARFID might restrict their diet to only 3 or 4 specific foods.
Just 3 or 4 things.
Yeah, to the point of severe clinical malnutrition. But because they aren't expressing a desire to be thin, the adults around them just mislabel it as extreme picky eating.
It's like we're security guards only looking for intruders wearing black ski masks.
That is a great way to put it.
Right. Like, if we only look for one highly publicized profile, the wealthy female demographic obsessing over body image, we completely miss the actual crisis happening right in front of us.
We absolutely do.
We miss the teenage boy on the wrestling team quietly developing bulimia to make weight. We miss the student from a low-income family whose ARFID is literally shutting down their digestive system.
And if we connect this to the bigger picture, missing those specific varied profiles has catastrophic consequences.
Because of the mortality rates, right?
Exactly. Eating disorders are classified among the highest mortality mental health conditions in existence.
Yeah.
We are dealing with illnesses that actively destroy the body's cardiovascular system.
Wow.
They destroy bone density and organ function. And because these disorders are so incredibly adept at hiding behind what looks like a normal exterior,
Hmm.
especially considering they affect people of all body sizes.
Right, so a student doesn't have to look severely underweight to be in heart failure.
Precisely. Which means identifying the behavioral shifts is quite literally a matter of life and death.
But those behavioral shifts are subtle, right? I mean, the documentation points to rapid weight changes, yes, but it also highlights food rituals.
Yeah, the rituals are a huge indicator.
Like obsessively cutting food into tiny pieces, sorting it by color, or moving it around the plate just to look like it was eaten.
Or taking frequent urgent trip to the bathroom immediately after lunch.
Right, or it's a student who used to love going out for pizza after the football game, suddenly withdrawing from any social event that involves food.
Exactly. And think about the physical environment where those specific behaviors manifest. They do not usually happen while sitting quietly in a row taking a history exam.
No, of course not. The primary theater for an eating disorder is the cafeteria.
Right. A high school cafeteria is a chaotic environment. You have intense peer observation, loud noises, and a strict 20-minute window to consume a meal.
It is a perfect storm.
It really is. It's a perfect storm for anxiety, sensory overload, and the activation of those food rituals.
Which places the burden of detection squarely onto the shoulders of the adults physically standing in that room. The school staff,
Yep. The teacher's on lunch duty.
a track coach, the school nurse, the guidance counselor, they are the ones watching these complex social and dietary dynamics unfold in real time.
And the reality of that environment forces these professionals to carry an enormous early identification responsibility. They are the frontline observers.
Because they see the kids every day.
Exactly. They see the student 5 days a week, meaning they can spot a baseline behavioral change far faster than a pediatrician who sees the child maybe once a year.
Right, that makes total sense.
But observation is not the same thing as a clinical diagnosis. And a diagnosis by a licensed clinician is the mandatory key to unlocking actual medical treatment.
But wait, so if a track coach spots a kid obsessively sorting food and refusing to eat before a meet, we can't expect that coach to make a clinical psychiatric evaluation.
No, absolutely not. They are an identifier, not a doctor.
Right. So they pull the school counselor aside, they trigger the school's referral process, and then what? Like, what actually happens next?
Well, currently, under the traditional siloed healthcare model, that referral pathway just hits a massive brick wall.
Oh, no.
Let's say the school staff does everything perfectly. They identify the warning signs and refer the family to an outside clinic. That pathway routinely dead ends in a terrifying 6-week wait list just to get an initial intake appointment with an eating disorder specialist.
6 weeks for an illness that is categorized as having one of the highest mortality rates in psychiatry.
Yes. In the context of a rapidly progressing psychiatric and physical illness, a 6-week delay is a systemic failure.
I mean, that's insane.
6 weeks is an eternity for a starving brain. In that month and a half, a teenager's metabolic system can become severely compromised.
Right, their body is literally shutting down.
Exactly. Furthermore, a starved brain simply cannot process complex cognitive tasks. If a student is suffering from the severe caloric deficit of anorexia or ARFID, their cognitive functioning just plummets. They cannot learn.
Which raises an important question. How do we circumvent that dangerous gap?
Right.
If a 6-week waitlist in the traditional clinical setting is essentially a death sentence for educational and physical well-being, how do we take a teacher's observation on a Tuesday and turn it into active clinical intervention by Wednesday?
And that is the exact logistical nightmare the MentalSpace school model is designed to dismantle.
Okay, so how do they do it?
To bypass that catastrophic waitlist, they are deploying a K-12 mental health support structure directly into Georgia schools using same-day teletherapy.
Same day, not next month.
Same-day intervention. Moving from a 6-week waiting room to a same-day digital intervention is just a monumental leap in public health logistics.
I bet.
And the mechanism behind this isn't just, handing a student an iPad and connecting them to some random outsourced call center.
Oh, so it's more integrated than that.
Much more. The model utilizes dedicated therapist teams assigned to specific schools. These are licensed, culturally competent, diverse clinicians who become familiar with the specific cultural and administrative ecosystem of the school district they are serving.
Here's where it gets really interesting. How does this actually function during a school day?
Good question.
I mean, it operates like an embedded in-house emergency response unit. A student in crisis can be securely connected to their dedicated teletherapist from a private office in the counselor's suite.
Exactly.
But just playing devil's advocate here, I can easily see how a Zoom call works for talking through generalized social anxiety. But how does a digital teletherapy model effectively treat something as intensely physical and severe as an eating disorder?
Well, the efficacy relies entirely on the specific evidence-based modalities that clinicians are trained to deliver.
Okay.
The model explicitly utilizes family-based treatment, which is widely known as FBT, or the Maudsley approach, alongside CBT-enhanced, or CBTE.
So these aren't just like unstructured venting sessions.
Not at all. These are highly rigorous clinical protocols. FBT, for example, is currently the gold standard for treating adolescent eating disorders.
Oh, wow.
Its core philosophy is empowering the family to take control of refeeding the adolescent at home, systematically disrupting those disordered eating behaviors.
So instead of sending the teenager away to a residential facility, the therapy empowers the parents to become the primary agents of recovery in their own kitchen.
Exactly.
But how does the school actually fit into that?
That is the genius of the embedded model. Think about a traditional system. A therapist might tell a student to eat their lunch. The student goes back to campus, and the school nurse or counselor has absolutely no idea what the clinical treatment plan
Oh,
is.
right, the student can just throw their sandwich away.
Exactly. But under the MentalSpace teletherapy model, the dedicated therapist coordinates directly with both the families and the school staff.
Oh, that changes everything.
It really does. The teletherapist can digitally communicate the FBT refeeding goals and CBTE coping strategies directly to the school counselor.
So the school and the home stop functioning as these separate, disconnected planets. The student has a united front of adults keeping them accountable in the cafeteria, in the classroom, and at the dinner table.
It creates a continuous, unified therapeutic environment. You see, an eating disorder thrives in secrecy, isolation, and the manipulation of divided adults.
Right, playing the adults off each other.
Exactly. So by linking the licensed therapist, the parents, and the school staff into one continuous communication loop, you effectively dismantle the disease's ability to hide.
That is incredibly smart.
And the model also layers in crisis intervention, suicide and violence prevention, staff wellness programs, and family counseling to support the parents who are executing these intense FBT protocols.
So what does this all mean for the schools trying to actually implement it? Because a brilliant clinical triangle is completely useless if families are locked out by exorbitant costs,
Oh, absolutely.
or if school districts are paralyzed by administrative red tape. I mean, systemic change almost always dies in the compliance office.
That is so true. The administrative and financial logistics are often the highest barriers to entry. You can have the best clinicians in the world, but if the operational friction is too high, the system will not scale across a state like Georgia.
But looking at the financial architecture of this model, they seem to have intentionally engineered those barriers out of existence.
They really have.
MentalSpace School accepts a massive roster of major commercial insurances. They cover almost all the major providers. But the detail that completely reframes this conversation is the Medicaid policy. Medicaid is $0.
Democratizing access to high-tier psychiatric care.
Yes.
Historically, receiving gold standard evidence-based treatments like FBT or CBTE was a luxury reserved almost exclusively for affluent families who could afford astronomical out-of-pocket clinic fees.
Right.
Low-income families, or those relying on Medicaid, were entirely stranded. They were just left to watch their children deteriorate on endless wait lists.
So reducing that cost to $0 for Medicaid patients literally removes the economic gatekeeping from survival.
Exactly. And from the district's perspective, the legal and compliance hurdles are addressed just as aggressively.
Right. The program operates with full HIPAA and FERPA compliance.
Bridging those two specific privacy laws is critical. HIPAA governs the strict privacy of a patient's medical records, while FERPA governs the privacy of a student's educational records.
Right. So you can't just mix them together carelessly.
No, operating a clinical medical intervention inside a public educational institution requires a highly secure digital infrastructure. You have to ensure data doesn't bleed improperly between a teacher's gradebook and a therapist's clinical notes.
Makes sense.
MentalSpace navigating both frameworks is what allows the school to legally host the medical intervention in the first place.
And there is a massive legislative hammer coming down in Georgia right now that makes all of this incredibly urgent for school boards, right?
Yes, Georgia's impending HB 268 compliance deadline hits in July 2026.
Let's talk about that deadline.
HB 268 is a legislative mandate forcing schools to implement actionable, structured mental health protocols and wraparound services. It fundamentally removes a district's ability to say, well, mental health care is a home problem, not a school problem.
Right, they can't pass the buck anymore.
Legally, they are now on the hook to provide an operational safety net for these students. And superintendents cannot just magically hire 50 new in-person child psychiatrists for their district.
Obviously not.
Those professionals simply do not exist in the labor pool, especially in rural areas. So telehealth becomes the only mathematically and geographically scalable solution to meet that July 2026 mandate.
Which explains why a plug-and-play, zero-barrier teletherapy infrastructure is so crucial.
Exactly.
But they aren't just offering compliance, right? The model tracks hard, quantifiable outcomes. The data shows an 89% improved attendance rate, a 92% reduction in anxiety, and an 85% family satisfaction rate.
Those numbers are huge. When a school administrator sees 89% improved attendance, they see a highly successful operational metric.
Because butts are in seats.
Right. There is a persistent debate in educational policy about whether public schools should even be in the business of mental health, with critics arguing that schools should exclusively focus on reading, writing, and math proficiency.
But for a parent listening right now, 89% improved attendance means your child is finally healthy enough to get out of bed,
Yes.
to handle the sensory environment of the cafeteria, and actually have a future again. You cannot teach a starved brain, and you certainly can't teach an empty desk.
Precisely. Bringing the care directly to the student, bypassing the waitlist, and involving the family completely restores the student's physical and cognitive capacity to learn.
It's all connected.
It is. Addressing severe mental health is not a distraction from the school's educational mission. It is the biological prerequisite that makes education possible in the first place.
Well, we have covered incredible ground today unpacking this infrastructure.
We really have.
We started by dismantling the dangerous, outdated stereotypes surrounding adolescent eating disorders, recognizing that high mortality illnesses like ARFID, anorexia, and bulimia are striking students of every demographic, race, and income level.
Yeah.
We looked at the terrifying reality of a 6-week clinic waitlist for a condition where rapid physical deterioration makes every single day critical.
And then we explored the mechanics of the MentalSpace school solution.
Right.
Empowering educators who observe the subtle signs in the cafeteria to instantly connect students to same-day, culturally competent teletherapy. By deploying evidence-based treatments like FBT and CBTE through a secure digital bridge, the model basically unites the therapist, the family, and the school staff into a single, cohesive shield around the student.
And it achieves all of this while navigating strict FERPA and HIPAA compliance for those impending state mandates. And most importantly, completely erasing the financial roadblocks for vulnerable families relying on Medicaid.
That $0 Medicaid point is just revolutionary.
It really is. Now, if you want to dive deeper into the logistics of this model for your own district or community, their operational framework is accessible at mentalspaceschool.com or by reaching out to MentalSpace School at jatherapy.com.
Definitely worth checking out.
Absolutely. Whether you are a parent navigating these exact challenges, a school administrator staring down a compliance deadline, or just someone fascinated by how systems evolve, this matters. The fundamental architecture of how we protect the next generation is being actively rewritten right now in our schools.
The structural shift we are witnessing is profound. And I'll leave you with this final thought to mull over.
Okay, let's hear it.
We've seen how efficiently this telehealth model bypasses the bottleneck of traditional clinics, instantly removing the economic and geographic barriers to gold standard psychiatric care.
Right.
If public schools can successfully integrate this rapid, unified healthcare model into their daily digital architecture, could this seamless, community-embedded approach eventually replace the traditional, siloed pediatric healthcare system entirely? Are we watching the obsolescence of the medical waiting room?
Wow. Now that is a fascinating question to consider. Are we moving past the waiting room altogether?
It certainly looks like it's possible.
Well, thank you for joining us on this deep dive. Keep asking those hard questions. Keep looking past the obvious stereotypes. And the next time you walk past a high school, remember, it isn't just a place for history exams. It is rapidly becoming the most vital, life-saving triage center in our community. See you next time.